Hello lovelies, and welcome to today's video. My name's Alya and I'm so glad you stopped by. So today we're talking about what it takes to get ready for cataract surgery. So really exciting and very different because today I'm actually going to be able to take you to work with me. I can't show you much just because of privacy and all that sort of jazz, but I'll show you as much as I can so that you will feel like you're an orthoptist getting cataract measurements. I was able to get some really great footage, so yeah, I hope you enjoyed today's video, even though it's a little bit different, and you get to feel like you were with me on the journey. Today is such a super special video because I don't think I've ever taken you to work before. So I'm really excited to be able to do that today. So the reason I'm usually not able to do that is I'm surrounded by patients and things like that and private information. So today is a bit different. Today is not my regular clinical day. Today I am going to be, as you heard in the introduction, working only on cataract calculations. So I thought it'd be interesting for you guys to come along and have a look at how that world comes together. So I'll be including clips of different stages of the process. Today I'll also be doing some measurements for particular patients who need some extra measurements done. So I'll be able to show you that segment, and then I'll show you where those measurements go and talk a little bit about why it's important to have certain measurements. So if you ever have to have any procedures done and you feel like you're having a bajillion tests done or a bajillion measurements done and you sort of start to think that your orthoptist's gone mad and it's way too much, well, today I'm hopeful to explain why it is that we go just as crazy as we do and where that all then gets applied. The most important part about preparing somebody for cataract surgery is getting a really great measurement of their dimensions, the dimensions of their eye. So the curvature of their cornea. Now, the way we do things is pretty straightforward. There are definitely surgeons out there that are going to map out the whole cornea segment by segment, and sometimes we do request for such tests to be done. The reality is you don't need it for a good outcome if it's just your regular eye. It's only important if the eye has had previous surgery or is somehow genetically or just naturally irregular. So if you get your regular eye, which most people we see will be, then you don't need any extra mapping of the cornea. Most scanners that are set up to prepare for cataract surgery will show you enough to guide an orthoptist whether or not further testing needs to be done. You can't always guess it, you can't always see it, but if something's off, we do send for extra scans. In the last 3 years, just to also grab a sample size outside of COVID, I think I might have sent altogether for about less than 10 scans outside of the clinic. So it's really very rare to pick up somebody with an irregularity, at least in my experience. Okay, so where normally I would start as an orthoptist is a refraction. I want to see what the person's best vision is at the point of when we meet, or the point when they actually say that they are ready for surgery, or we say that they're ready for surgery. I want to know their starting point, where they're reading and where they're seeing in the distance. That's really important, most of all for understanding someone's needs. So if someone's always been able to read without glasses, for example, but then can't see in the distance, I need to be able to explain to them and decide with them what they're going to be needing after surgery. Because during cataract surgery, we change all of that. So we can decide what to change it to. We can change it to stay the same in terms of capabilities. So to keep someone reading without glasses, we can turn it into monovision. We can have one eye reading, one eye seeing in the distance, or we can have both eyes in the distance. So where I start is the actual measurements of vision, a little bit of history. So often I like to see a lot of old glasses to see where someone was before they developed cataracts, and also just talk to them. I spent a lot of time just understanding what it is this person does. Do you drive a lot? Do you spend most of your time in front of a computer? Are you a musician? Are you a dancer? Are you someone who likes to cross stitch? All of these things are extremely important for my decisions when it comes to doing the actual choosing of the lens. We don't use multifocal lenses in the clinic. There's a lot of different reasons for that, but the main reason is they just still aren't great. Okay, every single patient I've come across that's had a multifocal lens put in has absolutely had some, well, they haven't hated it. I take that back. They haven't hated it, but they haven't been happy. And until I can get a lens where patients, at least 80% of patients, are going to be happy with it, like what we have at the moment with the other lenses that we use, I'm just not ready to do that to people. This is a surgery that can't be undone. So the other thing is long term. So they might be happy initially, but long term it just doesn't work out for people. So they're getting better, multifocal lenses inside the eye, but they're just not without their consequences. And I personally am not prepared to subscribe people to a lifetime of not really happy with their eyes. In my experience, most surgeons will have a very small candidacy for people who have multifocal, if they do multifocal at all, but in the vast majority still get a mixture of various types of monovision lenses or monofocal lenses, depending what they need. So once we've established what you need, whether you're going to have a reading eye or a distance eye or something in between, once we know what your needs are and what your visual expectations are, we need to check the back of your eye. Now, we don't necessarily do the test in this exact order, but if your surgeon hasn't had a really comprehensive look at the back of your eye before doing any kind of surgery, I don't care what kind of surgery you're going to have, they're not doing the right thing. Now, if you have an otherwise healthy eye and the surgeon's just able to see the back of your eye using their microscope, that might be sufficient. But I would say most of the time, if you're going to need any kind of procedure done, it's better to have a scan of at least your macula, but better the macula and the nerve. The reason for that is that a lot of ocular diseases are not easily detectable. A lot of them are hidden. So if you get a scan that tells you how many cells exist at the back of your eye, and in what population and what kind of concentrations they are there, you'll be doing yourself a huge favor. Huge favor. Huge. Why? Because no surprises. No surprises today, no surprises a year away from now, no surprises. So once I know that the back of the eye is really healthy and there's nothing to worry about in terms of retinal health, then we can move on to the rest of the exam. Or sometimes that's where we have started, but we're not talking about which order we're going in, we're just talking about what's needed here. I also like to take some photography of the back of the eye if I can, if it's possible. Obviously, when it comes to cataract, it's not always possible. If there's any funny looking anatomy, I'll have a record of it so that I can then come back after surgery and see what was induced by surgery and what was there already, because then the treatment of whatever changes we might find after surgery will be very different to something that was chronic or something that was present previous and something that wasn't. So that's very important as well, or at least find some sort of way to record anything that you find at the back of the eye, just to know how to deal with it after surgery. The actual A scanner that is most common will take a picture or a measurement of several points of the cornea before anything else. Because it uses several points of cornea, it gives you a really good demonstration of the whole area. Newer machines will use more points, older machines will use fewer, but they're all kind of much of a muchness really. It just makes the orthopter's job a little bit harder if you have an older machine, but really, in inexperienced hands you get really good results no matter what. And as I mentioned, there's always other tests you can do if your machine isn't doing enough or is throwing out some confusing results or anything like that. So that's all very fixable. Once you have your corneal measurements, and that's talking about corneal curvature, the cornea, if you want to learn more about it, I have a whole video about it, is a curved structure. It looks a bit like a contact lens, but it's a natural one. It comes somewhere around 550 microns thick, and it varies quite vastly person to person, and it is responsible for quite a lot of our refraction or our vision. And the one thing that doesn't really change too much during surgery is that cornea. So we really need to know as much as we can about it beforehand and know how to work with it. We need to know what curvature it is on the surface, what curvature it has underneath the surface, on the back side of it. We need to know, how it's placed and how it's, just as much as we can, so we can plan around how it's going to affect the outcome of the surgery. Another really important measurement is the depth of the anterior chamber. So the chamber that starts at the back of the cornea and finishes sort of around the iris, that chamber depth is also quite variable person to person and will also affect how long light has to travel through the front segment of the eye before it hits the new lens. The new lens will sit in the natural sac that we all have holding our lens that we have naturally. So once we know what the depth of that depth is at the beginning, we can kind of use it going forward. That's a really important measurement and very significant to the outcome, or what the expectations are, or how we calculate our expectations preoperatively. The next thing we need to find out is the very, very important, the length of the eye. Again, how long the light has to travel will give us, in turn, the power that we need for the light to travel there. So if you have, let's say, a 23 millimeter eye, that will then translate to, I don't know, let's pretend for a second a 23 diopter lens. Doesn't quite work that way, because remember, we have to worry about the power of the cornea, the depth of the anterior chamber, and the other really important part is the width of the front of the eye, the width of the cornea, or the white to white, the section between this part of the white and that part of the white, so the white to white. Most people have around 11 to 12 millimeters. It's a very small section, but it does make a difference. The other thing that's really important surgically is that there's enough room between the different areas to get in there and do the surgery. And depending what you're dealing with, it will vary as well. It will affect the way the surgeon works. Every single surgeon has a different statistic that we then have to enter into our formula in order to work out what the outcome is going to be. So I'm hoping to shed some light on what happens after the patient leaves the clinic, and where the orthoptist has to really do the hard work.
Here's my lovely 83-year-old lady with very dry eyes, and I've lubricated her, but she's moving a lot, as you can see.
So this is our immersion scanner. So what it does is we fill up using saline solution through this little tube here, and it goes all the way down this pipe into this eye bath, which sits on the patient's eye, and a little light can be seen inside. And then using ultrasound, you get these beautiful A scans. So this is representing the front of the eye, the central part of the eye, and then that line, that beautiful straight line there, is the retinal plane. So a very, very good standard deviation there. Fantastic results. We also use manual keratometry sometimes, just another way to measure the front of the eye. So as you can see, there's a lot of moments to go through as an orthoptist preparing somebody for refractive surgery. This is just intraocular lens surgery or cataract surgery. It does vary if you're having, say, LASIK or some sort of corneal refractive surgery. Typically that's done to younger people, whereas cataracts are reserved for either older people or people who've had other surgeries that have induced cataract growth. So this won't apply to everyone. Different machines will then have different functions and different features. So sometimes you'll need fewer machines, or maybe you'll need more machines to get the same results. But this is the basic stuff that the formula requires for us to have a predicted outcome.
Okay, so this is the old generation calculator that we used to use. So up here, let's see if I can get my bearings through the camera. Up here you would write the doctor's name, say just doc. Because if you're working in a clinic with several different doctors, you want to be able to differentiate. You've got your patient's name. Okay, we'll call him G. Dad. I don't know. And here is an important window for me personally, because as you've seen, we can sometimes use different machines. For example, I used the general keratometer, which is the IOL master. So I'll put IOL K here, which means the corneal curvature, which we call keratometry, was done by the IOL master. But sometimes I might use the manual keratometer, which I showed you, and that's when I would put in the manual case. And that will differ down here where I put my measurements. The other really important thing, and you'll see when I press it, is which eye we choose. So let's pretend it's the right eye that we're going to operate on. So as you can see, when we hit continue, it showed me that the incision side is at 180, which is the temporal side, because we're looking at the right eye. So that's the nose, that's the ear side. We've already told them that the curvature is at 90 and 180, and then this is the stuff that it tells me, which is going to help me decide on lens. So we go continue again, and then it tells me which type of lens I want to be using. Now the reason it gives me this particular code is because I'm using the Alcon Acrosoft IQ lens specific calculator. So that's an old school way of doing things. In today's world, I use something like this. This is a previous patient's calculations that I did here. I entered it all in a very similar way. Hopefully it won't lose it when I click away, but basically same idea. I've got manual K here. I've got the first K, the second K, the angles. It's showing me where the incision's going to be. It's showing me where the lens should be placed. It's showing me the power outcome, everything. This is Barrett's. Barrett's is the most, or not the most, but one of the newer calculators that we've had really great success with. And just like before, you'll see that there's an opportunity to put in the doctor's name, to put in the patient's name, to put in the type of keratometer, the type of lens. Here you can choose just about any lens that there is in existence. It will come up with the features of that lens, and then you enter the individual thing for that particular patient. You'll see that I use the same doctor's input, everything. Then when I hit calculate, it brings me up an eye, explains that this is the incision, the different curvatures, it shows me a nose, and then I'll click here and it'll tell me what lens I want to use. So I've got another calculator that I use sometimes. This is for non-toric. Toric just means that somebody would have astigmatism or a little bit more curvature in one direction than the other in their cornea that we have to compensate for. If they don't have a little bit more curvature in one direction than the other, then we have nothing to compensate for, and that's when I'll use this formula. I also use printouts from the actual IOL master to help me, plus another one called the Holiday 2 program, which is much more refinable and much more specific to the doctor that you're working with, and it just does a few extra bits and bobs, which was much more useful before we had this Barrett's. Now it's a little bit, I don't know, it's had its day, but we still use it because we like to do all the things.
The more surgeries a doctor has done, the more clear you are on what their statistics are, and the more you can fiddle with the formula to know exactly what to put in. Different doctors will also use different formulas. The formulas I've shown you today are the ones that we use in the clinic, or at least the ones that we use most commonly in the clinic. There's definitely more to what we do. I just cannot reveal everything for various reasons, but I'm just wanting to show you guys what goes into it without sort of divulging too much. This is just the bare minimum of what we require to get that outcome for our patients. We have had some patients that have had really, really dense, horrible cataracts. I can't explain how it is that they got so bad. In Australia, cataract surgery is extremely accessible at any socioeconomic level. You can have cataract surgery. It's extremely affordable in the public system and accessible in the public system. Some people, I think, are just fearful of the unknown, and that's what's delayed them. Some people have had one eye that's really good, one eye that's really bad, and they've just thought, oh, it's old age or something like that, or oh, I injured that eye as a child, or they've made some excuse and as a result have delayed their surgery, which is really unfortunate. It makes things a little bit more difficult and interesting clinically and surgically, but it's never too late. It just, the risks obviously increase when we can't see what we're doing, and then you can use things like lasers to assist. So for that reason, because we have had a decent number of very severe cataracts, we do have an ultrasound scanner in the clinic. Not as accurate or as good as the new machines, but it is definitely there for those who have a really tough eye. And it's also there as a backup. So if you're ever unsure, if something's unclear, it can definitely confirm your measurements for you. Different machines have different results as well. They're all calibrated to their own standard. So that's something else that as a clinician, you just got to know your machines and you have to adjust for that. I hope today was interesting. I've never taken you guys into the clinic before, so this was a little bit different for me, but I hope you enjoyed learning a little bit about what it is I do, and definitely this is just a small drop in the ocean of what I do, but it's a pretty significant part of my job, and it's definitely one that I take extremely seriously. It was exciting to share it with you all. If you liked today's video, please do hit like and subscribe for more of this type of content. For more bits and pieces, please head over to Instagram, where there's just definitely more broad stuff going on and a bit more about kids and tickles and life and all that sort of thing. And wherever you are in the world, my lovelies, I hope you're having an amazing day. You're staying healthy and happy and safe, and I can't wait to see you on the next one. Bye.